Okay, very good morning to all. First of all, I would like to thank Dr. P.S. Mohammed Hadi, our chairman, Principal Dr. Vinod Kumar sir, and Dean Harry sir. And I would like to thank all the entire team of Department of Conservative Dentistry and Department of Oral Medicine and Radiology to give an opportunity to present a webinar on a topic, Beam to Future, that is basics of quantum computed tomography and presenting. It's actually quantum computed tomography in endodontics, but I'm not going deep. It's just an introduction for quantum computed tomography.
Rahul, Doctor, could you come a little more closer to the mic? I think the volume is a little less.
So it's audible now?
Yeah.
A frequently asked question when referring a patient to CBCT was what is CBCT and when CBCT should be referred and why the CBCT can be taken, or why CBCT. And first of all, we have to know about what is CBCT. And CBCT is a compact, faster, and safer imaging technology when compared to other advanced imaging modalities or advanced imaging technologies. A compact means the machine size is very small. You can comparable with OPG machine when comparing to other advanced imaging modalities like CT, MRI, and it's a faster imaging technology that we will get a volumetric image or a full scan in less than 1 minute. And also it's a safer imaging technique that reduced dose or a radiation dose to the patient is very less, and also give a very improved quality of data or image in an affordable expense for the patients. Actually, the CBCT works on the principle of 3D imaging technology. By this, we can take teeth and other maxillofacial structures. Actually, there are some evidences in literature from 1899 onwards. The radiology was used as a pivotal tool in the practice of endodontics. And the next question was when CBCT should be referred, or when CBCT should be taken. Whenever 2D images are not sufficient for proper diagnosis, we can refer the patient to CBCT for 3D imaging. We all know that there are some limitations for the 2D images when comparing to 3D images. 2D images have some magnification problem, distortions, and superimpositions of anatomic structures. As like a 2D image, it's a 2D cartoon character, Mario, and it was converted into 3D structure. This will give more information, more realistic and more depth for the viewers to have a enjoyable session. Like we can have more information about the lesion, the extension of the lesion, like that. And why CBCT was taken. When comparing to other technologies like CT, we get a highly detailed 3D view in low radiation exposure. That is a specialty of CBCT or 3D image. The 2D image, just assume this as a 2D image for an example. Just we will think that the cub, the lioness is swallowing her baby or the cub. But if this image was taken in another angle, or this is taken with a 3D imaging system, just we can see just she is carrying her baby. I'm not going deep into the history part, but first generation CBCT was first used in 1982 to perform angiography, but it was a failure, and this CBCT system was extended to other medical sections, especially dental and maxillofacial region study. And quantum technology was first introduced in European market. The first machine was Newton 9000. Here is the picture of that machine, Newton 9000. And as a PSM staff or a PSM, the whole PSM family was proud to have a machine that is the same branded machine, Newton Giano XR. This is that machine in our department of oral medicine and radiology. And there are some specifications that CBCT over CT, like first the shape of the cone or shape of the radiation, shape of the beam. CT uses a fan-shaped beam that they will have a multiple axial sections with this fan-shaped beam. So the patient got more exposure to the radiation. But for CBCT, we use a cone-beamed shape or a cone-beamed radiation to get a volumetric image in a single scan. So the patient will get less exposure when compared to CT. And coming to the dose of the CBCT, CBCT only uses 25 to 60 millisievert, but medical CT uses around 1,200 to 3,300 millisievert. That is 20 to 30 times more than the CBCT. And other specifications that CBCT over CT are, CT have a longer scanning time when comparing to CBCT. We all know that fan-shaped beam will take multiple axial sections to reform into 3D structure. So there will be more exposure to the patient and more time needed to take an image. And the CBCT image is a little bit difficult when compared to CBCT image because they have limited axial sections for the interpretation. And cost of the equipment is a little bit higher than CBCT machines, and equipment is lighter and smaller. The CBCT machine is a lighter and smaller and compact machine when compared to CT. We all know that the CT machine here in this picture, we can see a CT machine which have a huge gantry which rotate around the patient. It's a huge machine. So the CBCT machine is lighter and smaller, and CBCT machine is very easy to operate and to enter. And in voxel size, voxel means as in our camera and all we have pixels. Like that, for scanning images, there are voxels. For CT, they use non-isotropic voxels. That here in this picture we can see a rectangular shaped voxel. So the spatial resolution will be very less for the CT images. And for CBCT, we use an isotropic voxels. That is a square like cubicle. We use this in the CBCT. So if we cut the image or if we alter the thickness of the image, the spatial resolution will not lose, or the spatial resolution will be high for CBCT. And each voxel is characterized by the height, width, and depth of the image. And there are extensive differentiation between the image formation in CT and CBCT. CT actually, I already told, the fan-shaped beam will take multiple axial sections like this apple, the first image, and this axial section is reformed into 3D image, like in the second picture. It's transformed into 3D structure. So multiple axial sections combined. But in CBCT, the first image or the first image taken by the CBCT was a 3D image or a volumetric image in a single scan. This volumetric image is then reformed into axial sections, then coronal section and sagittal sections. Along with the 3D view, we can also have two planar images like axial, sagittal, and coronal image. When knowing the CBCT, there are some terminologies that are important. That is, the first one is FOV, that is the field of view. Then the DICOM format, then multiplanar reformation and artifacts. Coming to the field of view or FOV, it is a collimation of X-ray beam. By adjustment of FOV, limited the radiation dose, and this depends on detector size and shape. It is variable from variable machines. Like Newton have one, and Planmeca have another, and ICAT another, like that. The detector size and shape of the FOVs are different for different machines. And it is desirable to limit the field size to the smallest volume that can be accommodated in the region of interest. If a patient is referred for CBCT, the doctor should write for not the tooth, exactly the tooth number or to the area where they want. So with that, we can adjust the FOV. Here, in picture, we can see a orange cylinder that denotes the FOV or the field of view. mostly there are three types of FOVs: the smaller FOV, the medium FOV, and the larger FOV. In smaller FOV, we mostly use this smaller FOV in endodontics because we only have a single tooth for two or three tooth and its adjacent structures. So we use a small FOV for endodontics mostly. But for attaining maxilla and mandibles, we use mostly the medium-sized FOV. And for post-operative and pre-operative surgical procedures or to detect any fractures, like that, we use large FOVs. And coming to the DICOM file format, this is a standardized file format that is used to share or transfer the medically images or medical file to another. The abbreviation was Digital Imaging and Communication in Medicine. We transfer this 3D images or CBCT images in a CD in a DICOM format, and we just add a viewer to view the file. And actually, the CBCT produces two data products. The first one is volumetric image data from the scan, that is the DICOM format, that we will provide to the patient in a CD with the viewer. And the second one is image report generated by the operator. That is, as if the image was taken, then we will analyze the image by measuring the lesion or measuring the structure, and we will give a report, a detailed report with the pictures to the patient as well as the doctor. And it will take some time for the operator or the radiologist to have a detailed report. And I already told we will provide CD to the patient with the images, the DICOM format, and we also include a viewer in that. And if you put it in the laptop or a computer, you will have a screen like this with some tools. And this is called the multiplanar reformation. You will get three 2D structures, 2D images with a 3D image. The 2D images are axial, coronal, and sagittal views, along with the 3D reformed structure. And the images can be manipulated in thickness. By scrolling the mouse, you can manipulate the thickness of the image, and you can appreciate the lesion or anything in the image. And the direction of viewing can be also altered. Like you can see a picture in this yellow and green line. You can just rotate or you can move it, and by this you can alter the viewing or the direction of the image. These are the two, I already told the three two-dimensional planar images, that is axial section, sagittal, and coronal section. This is the picture of axial section. The black line denotes the axial cut that we are seeing in the second picture. This is the line, and here the axial section. And we are just looking from the top of the skull. Here, so this is used for endodontics for appreciate the morphology of root canal or root. Like here in this picture, we can also see a three-rooted molar, like the mesobuccal tusk, the osteobuccal tusk, and the clavicle tusk. By looking this, we can appreciate a missed canal or any fracture instruments, root morphology like that. And the second one is the coronal section. As we seeing from a front region, this black line denotes coronal cut. In this picture, we can see and appreciate the coronal cut. Like we can see the sinus and the tooth was sectioned coronally. Means coronal section of the we can see a maxillary sinus and all. And the next one is sagittal section that we are just looking from the side of the patient. We can cut the patient sagittally. The black line denotes the sagittal cut. And here you can see a tooth sectioned sagittal. Like we can see a periapical pathology, or you can see any internal or external resorption, any morphological changes in the root or coronal aspect. Everything you can see. And we can compare it with anatomical structures nearby, like if there is a periapical cyst or any lesions, we can appreciate more like incisive canal or mandibular canal or like that. and we can measure the length from the anatomical structure to the periapical region or to the tooth, like from the maxillary sinus, from the incisive foramen, incisive canal, inferior nerve canal. The next main topic was artifacts. For endodontics, there are for CBCT, and the CBCT mostly have artifacts, that is metal artifacts. When any metal restoration was retained in the socket or in the cavity, if we take a CBCT image, we will get some metal artifacts. So before referring to a CBCT, they should have to remove the metal restorations or metal part of the restoration. So we will get a clearer image without the artifacts or a metal artifact. An artifact is any distortion or error in the image that is unrelated to the substance being studied. And CBCT images inherently have more artifacts than CT images, and artifacts can be classified according to their etiology. There are so many artifacts like motion artifacts, streak artifacts, and beam hardening artifacts, metal artifacts, on-beam artifacts. There are so many artifacts, but mostly in endodontics, we will go through the metal artifacts. In this picture, we can see the patient is wearing a fixed orthodontic appliance and crown. So we'll get more metal artifacts. The image will get more distorted because of metal artifacts. And the measurement of the image will be variable because of this artifact. So better remove the metal restoration or metal part from the patient mouth before sending the patient to CBCT. And as any imaging modality, CBCT also have some strengths and limitations. Strengths of CBCT are size and cost. I already told. Then sub-millimeter resolution, then relatively low patient dose when compared to other advanced imaging modalities. Interactive analysis, it is one of the most most useful thing for CBCT. You can interact with the patient by showing the 3D image to the patient. Because if it's a 2D image, the patient can't recognize or appreciate the image, as we have the practice of appreciate lesions from the 2D image, but the patient will not. So we can interact with the patient by showing 3D images and by measuring the lesion that we can show it to the patient. Then image accuracy of CBCT machine was very good. CBCT machine provides isotropic voxels. So I already told, and rapid scan time. Then display mode unique to maxillofacial imaging. CBCT have a display mode that, especially for maxillofacial imaging, we can, by scrolling the mouse, we can alter the thickness and the direction of the image. We can have minute slices of images to recognize or to measure the accurate length of the lesion or a pathology. And reduced image artifacts. Actually, I already told CBCT have more artifacts than CT, but reduced image artifact means for a newer imaging technology or newer imaging machines, 3D machines or CBCT machines, they are using new reduced metal artifact reducers, that is MAR, metal artifact reducers, or other artifact reducers to combine with the software to reduce the artifacts and have a more high quality pictures. And limitations of CBCT, the most one of the worst limitation of CBCT that everyone will tell was soft tissue contrast. It has a low soft tissue contrast when comparing to other. The CT also have some soft tissue contrast and MRI that we all know, but CBCT have a limitation in soft tissue contrast, because if there is a lesion in the soft tissue, we can't recognize as that of advanced imaging technology. The measurement and all, we just have to have another imaging technology for soft tissue lesions. And Hounsfield unit was not reliable in CBCT. Actually, Hounsfield unit is also called as CT unit or CT number. Hounsfield unit is a quantitative measurement of the bone density. Like we can have 1,000 for the variable ounce field unit denotes variable structures like fat, like hair, fluidic, then bone, like that. So CBCT is little bit lesser ounce field unit than this CT machines. And dose of CBCT when comparing to other 2D imaging modalities or 2D dental imaging, dose is little bit higher for CBCT. And one of the most limitation was the knowledge and awareness to dental practitioners was very limited for CBCT. Then cost factor, and comparing to other 2D images, cost factor is a little bit higher. And artifacts, I already told the artifact is more in CBCT in comparing with other products. I'm not going too deep about endodontics, just brushing up. Evaluation of root canal morphology can be evaluated, then 3D representation of periapical pathology, then assessment of pathosis of endodontic and non-endodontic origin, identifying an untreated or missed canal, visualizing overextended root canal obturation material, analysis of external and internal root resorption, evaluation of vertical and horizontal root fractures, and you can evaluate fractured instruments and locate where this fracture instrument, the exact location we can trace. And here is a case from our college or department. It's just a video showing the missed canal. One is an endodontically treated tooth, and here the black line denotes the missed canal. You can see the pulse chamber here. Like that, we can measure, or we can have a exact location and measurement of the image for the pathology. And the case 2 here, it's a 2D image. The first image is a 2D image. We already told the 2D images have some superimpositions of anatomical structures, and this is a 3D sagittal view showing a 2 centimeter pathology in the periapical region of the molar, and the image is a little bit blurred because of the metal artifact. And this is a case 3 for fractures, especially in horizontal fractures. For 2D images, the rays or the radiation will be the same direction as that of the fracture. So it is very difficult to appreciate a horizontal fracture in 2-dimensional image. But for a 3-dimensional image, you can cut this image into axial and sagittal or coronal sections, and we can appreciate more on the lesions like fractures and all. In this second picture, you can see the fracture, the horizontal fracture, in the periapical third. And coming to the Richter's form, actually this is the common Richter's form for our radiology department. And if the here the patient name, age, and OP number should be given. And if anyone is referring a patient, they can give a tick mark in the others and write CBCT of which region the image should be taken, CBCT of 1-1 or 2-1 or left mandible or like that. And you can give you can also write about the details you want. Like in this picture, if you want to know about the length of the tooth, or is there any proximal caries or any pathologies, or size of the lesion, exact location of the lesion, just you can write the points or the details you want in this request form. And also we want the name of the doctor and WhatsApp number to contact if there is any doubt, or we are mostly sharing the PDF format report to the doctors. And if they give the WhatsApp number, we just have easy to share the exact PDF format report to the doctors. And there are after the what, why, and when question, and another frequent question by the patient is that this radiation will cause cancer to the patient. And if the diagnosable radiation risk was taken by the patient, And if the patient got any some benefits from the risk or by the image, then the sentence that the benefit outweighs the risk. By this, I am concluding my webinar on the introduction of basics of CBC. And thank you very much.
Thank you, Dr. Rahul. That was a very informative talk by Dr. Rahul on CBCT. I hope everyone has got a basic information regarding the CBCT